Hello everyone, I am Sulufan from the First Clinical College. Today, we are going to learn dilated cardiomyopathy. Before we start, let's come to know cardiomyopathy first. Cardiomyopathy is a combined word. It can be separated into cardio, myo, and pathy. This stands for heart, muscle, disease, respectively in the Greek language. However, it is not a single disease. It refers to a heterogeneous group of diseases. It is associated with mechanical and/or electrical dysfunction and usually exhibits inappropriate dilatation or hypertrophy, which are due to a variety of causes, especially the genetic reason. This term is intended to exclude the myocardial change induced by other cardiovascular disorders, such as coronary heart disease, congenital heart disease, valvular heart disease, and hypertension. Cardiomyopathy can be classified into dilated, hypertrophic, restrictive, and some other types. This class will only talk about dilated cardiomyopathy. We can use the initial letters D, C, M for short. Suppose this is a normal heart. The features of the dilated cardiomyopathy is like this. We can see enlarged ventricles, especially the left ventricle, with the thin wall of the heart. As a result, the systolic function is reduced. So the two features are enlarged left ventricle or both ventricles with decreased systolic function. Besides the dilatation of the ventricle and the thin wall, sometimes there will be some mural thrombus on the wall, and we can see the myocardium is replaced with fibrous tissue. And also, the coronary arteries and valves should be normal. Under the microscope, we can see there are interstitial fibrosis, and the myocyte is often hypertrophic with enlarged irregular nuclei. The etiology of the dilated cardiomyopathy is diverse. Besides what I mentioned at the beginning, the genetic reason, there are some other causes, including pathogen infection, especially the virus infection, non-infectious inflammation, some toxic agents, for example, high dose of alcohol and chemotherapy. Also, the metabolic or endocrinal disorders and deficiency and some essential nutrients can cause dilated cardiomyopathy. There is a special type, we call it peripartum cardiomyopathy. It is associated with pregnancy. Even so, there are still 2/3 of cases are with unknown reasons. We call it idiopathic. Sometimes we attribute the reasons to some unrecognized gene defects. The clinical manifestations can be summarized as dilated ventricles, heart failure, arrhythmias, and embolism. Dilated ventricle is the feature of the heart. Because there is decreased systolic function, sometimes the patient presents heart failure. And due to electrical dysfunction, arrhythmias are relatively common. And embolism usually originates from the mural thrombus. During the physical examination, the signs we can find are usually associated with heart failure. If the heart failure affects the left heart, we will hear the crackles and wheezings in both lungs, and we will detect an enlarged heart border. In auscultation, we will hear the fast heartbeat with weak heart sound, and S3, S4 sound, and gallop rhythm. Sometimes we can hear them. Maybe there is an apical systolic murmur. That is because the left ventricle dilatation causes a relative dilatation of the mitral annulus. So that is why we can hear this murmur. If the heart failure affects the right heart, we will find the distension of jugular vein and hepatic distension, and also peripheral edema. In the chest X-ray, we will see a very big heart shadow. The heart-chest ratio is over 50%. Sometimes it is with the pulmonary congestion. In the ECG, the manifestations is usually non-specific. We can see some tachycardia or left branch block, SCT change, or Q wave. But please note, sometimes there will be the ventricular tachycardia and ventricular fibrillation. These are all some fatal arrhythmias. Echocardiogram is a very important examination for DCM because in this figure we can see a large left ventricle and with the thin wall. The wall motion is globally weak, not segmentally. This is a point to differentiate with the ischemic cardiomyopathy. If we measure the left ventricle ejection fraction, it is usually reduced, lower than the normal value. Sometimes we can see the mitral regurgitation because of the dilatation of the mitral annulus. This is CMR, which is a good method to detect the myocardium. From this video, we can see the heart are enlarged and with thin wall and globally weak motion. The systolic function is reduced. These are all typical change of DCM. In lab examination, we will find the biomarker of the heart failure elevated. For example, the BNP and NT-proBNP, they are all elevated and higher than normal value. The diagnosis of DCM from the clinical manifestations, such as the ventricle enlargement and the clinical manifestations of heart failure. Arrhythmias and embolism are not always necessary. If we will find some typical findings on the echocardiography or the CMR, we will suspect DCM. However, we need to exclude some other causes. For example, the causes from valvular heart disease, hypertensive heart disease, coronary heart disease, and some other specific types of cardiomyopathies. Then we will get the conclusion that this is DCM. About the treatment is associated with the treatment of the causes, heart failure, arrhythmias and embolism. Do remember, the treatment of causes always comes first. Medication is the basic treatment of this disease. If the patient presents heart failure, we can choose the medicines as follows. And you can recommend the chapter of heart failure. If the patient has some arrhythmias, sometimes we may choose the beta blocker and amiodarone. For thrombus embolism, if we want to prevent embolism, we can use the anticoagulants such as warfarin or some NOAC. Recently, there are some devices used in the treatment. For example, the CRT, ICD, and LVAD. CRT and ICD are all specific kind of pacemakers. CRT can help the left ventricle and the right ventricle work coordinately. This will improve heart function. ICD can detect some fatal arrhythmias and will do defibrillations when necessary. LVAD is just like an artificial heart and lungs. It can help the circulation and oxygenation of circulation. However, for the very failed heart, the final choice is heart transplant. The prognosis of DCM is poor. The 5-year survival rate is only about 50%. The major cause of death for the young people are usually due to fatal arrhythmias. And the major causes of death for old patients are often the refractory heart failure. Next class, we're going to learn hypertrophic cardiomyopathy. See you next time.